Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today we're going to be talking about digestion and absorption. Does not sound like the most exciting video that you've probably ever watched, but these are the kinds of questions that I am more likely to miss, or I would be more likely to miss on the NCLEX because I know the least about them. Like I'm good at cardiac stuff. I'm good at respiratory stuff. I'm even pretty good at renal stuff. But digestion, absorption, not my best topic. So let's go ahead and review some of these things. Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews, the home of the very best NCLEX review in the entire universe. In my opinion, Mark Klimek is the GOAT of NCLEX prep. You can go to clinicreviews.com. Right on the homepage, you'll see information about our streaming service. You can also click on the on-demand link, which is up in the right-hand corner, to learn more about the 21-plus hour NCLEX review. And you can also click on the online tutoring link where you can meet me live over Zoom if you want to do small group tutoring. So let's go ahead and get started with our digestion and absorption conceptual questions. A client with months of diarrhea and bruising has the following labs: a hemoglobin of 11, which is low. 12 to 18 is where you want it to be. Albumin of 2.9, which is low. I don't remember exactly the range, but I do know albumin in the 2s is low. INR of 2.2, which is high, but they're not on an anticoagulant. Potassium of 3.6, which is actually normal. 3.5 to 5 is normal. Which lab needs immediate follow-up? Well, I'm going to cross off the potassium because that's one is normal. So we have diarrhea and bruising. So they could be losing electrolytes, but their potassium is fine. Bruising tells me maybe they're bleeding easily or failing to clot very well. So the hemoglobin could be low because of the bruising. So the bruising could be causing the low hemoglobin, perhaps. What is the worst outcome of a hemoglobin of 11? Really, it's not low enough to be concerned about. I'm not usually concerned unless the hemoglobin is less than 8. So I don't see any negative outcomes of a hemoglobin of 11 at this point. Albumin of 2.9. What's the worst outcome of an albumin of 2.9? It's an indicator of nutrition, of overall protein, and so they're probably malnourished somewhat, and it also could result in ascites, peripheral edema, which is not life-threatening. INR of 2.2 when they're not on an anticoagulant could result in bleeding. So which of these abnormal labs, A, B, or C, could have the worst outcome? The one that could have the worst outcome would be C if they end up bleeding more than they should, which they are actually having some bruising. So that's the one that requires immediate follow-up. All right, after terminal ileum resection, which complication is most expected? Severe iron deficiency, vitamin B12 deficiency with neuropathy, profound lactose intolerance, or hypercalcemia? Okay, so in general, for thinking conceptually, what I would encourage you to remember is that the large intestine absorbs electrolytes and fluid. Not all the fluid. There's quite a bit of fluid absorbed in the small intestine too, but if quite a bit of fluid is also, that's why if you have diarrhea, it's because the fluid's not being absorbed in the large intestine. So it's fluid and electrolytes in the large intestine, where the small intestine is more about nutrition. It absorbs nutrients. And vitamins, I would say, is part of nutrients, but it's also proteins, fats, and carbohydrates. So if the small intestine isn't working, they're very malnourished. Whereas the large intestine, if it's not working, it's a fluid and electrolyte issue, okay? So iron is one of the few things that is absorbed actually in the stomach and the duodenum. Do you want to remember that? Yeah, you can remember that. I think that's not a bad thing to remember. Vitamin B12 is part of the nutrition that I think about, so I think that's probably small intestine, and the ileum is small intestine. Profound lactose intolerance. Actually, lactose is absorbed because of, I think it's lactase or lactate. It's lactase, I think, which is actually produced, not absorbed. So if you can't absorb lactose, it's a production problem And then hypercalcemia is electrolytes, which I think more of large intestine. So I'm going to go with the nutrition option, which is vitamin B12. Interventions to prevent dumping syndrome after gastric surgery include, select all that apply. All right, you do need to know about dumping syndrome. So dumping syndrome is when there is a smaller holding area for the chyme. CHYME is chyme. Chyme is the digested food that leaves the stomach. Okay, so it's broken down, starting to be broken down in the stomach, and some things are absorbed. Iron, for example, is absorbed. Most things are not absorbed in the stomach. They're just digested, right? And so chyme is the digested food that leaves the stomach. And if the stomach has a very small area for holding, then things exit the stomach too fast. Or if they bypass around and there's the stomach and the duodenum, then things are just going to move too fast. So dumping syndrome is moving too quickly into the small intestine, and it has symptoms. It has symptoms of abdominal pain. It has symptoms of diarrhea, can have some diarrhea, primarily nausea and abdominal pain. Those are kind of the big ones. And so we want to prevent food or chyme from dumping out of or into the duodenum too quickly. So how can we do that? So let's look at our options. Eat small, frequent, high-protein meals, limit simple sugars, drink fluids between meals, lie down or rest after eating, choose high-carbohydrate, low-protein meals, increase liquids with meals to aid transit. So here's the rules to prevent dumping syndrome. First of all, you can position. So if you position flat, then it doesn't exit the stomach as quickly, because if you're sitting up after you eat, not during. If you sit up, you always sit up while you're eating. If you sit up after you eat, just gravity alone is going to move things more quickly. So laying flat is the appropriate position to avoid dumping syndrome. And then the contents of what you eat also help avoid dumping syndrome. So proteins and fats stay in the stomach longer, and carbohydrates move more quickly. That's why after you eat a high-fat, high-protein meal, you feel full longer than if you eat a high carbohydrate meal. So you can slow transit by eating high fat, high protein meals. Probably better to do high protein than high fat. We never recommend high fat, but high protein meals are going to help. Laying down, and then if you drink with your food, if you drink fluids with your food while you're eating it, it actually promotes transit time. It decreases transit time. So it moves more quickly. It's just, you're just making it more liquidy if you drink a lot with the food. So anyone who's had gastric bypass or any kind of weight loss surgery, we say you cannot drink fluids with your food. You can drink as much fluid as you want to, but you can't drink fluids with your meal. If you're going to eat, you have to eat food and then wait a little while, and then you can have something to drink. Okay, so let's look at our options. Eat small, frequent, high-protein meals. That's fine. Smaller, more frequent meals that are high in protein, those are going to move more slowly. That's a great option. Limit simple sugars. Well, that's limiting carbohydrates, so that's a good option. Drink fluids between meals. That's correct. You want to drink fluids between meals. Lie down or rest after eating. Yes, you want to lie down after you eat. Choose high-carb, low-protein meals. No, because those are going to move more quickly. Increase liquids with meals to aid in transit. No, that's not what you do. Plus, it's the opposite of C. So C and F are opposite answers. So one of them's got to be right. And if C is right, then F cannot be right. A client with chronic pancreatitis on enzyme replacement, what finding shows the dose is inadequate? So the pancreas secretes enzymes that help with absorption and digestion of fats, and carbohydrates. So if they have chronic pancreatitis and they're on enzyme replacement, what finding shows the dose is inadequate? So if something is normal, then the dose must be okay. 1 to 2 formed stools daily. Well, that's normal. So that should not be a problem. Mild constipation. I'll tell you, whenever I see the word mild on an NCLEX answer, I always think that's fine. They kind of use the word mild to indicate that this is sort of normal. Like we all have mild things, like a mild headache, a mild constipation. Like those are things everybody sort of gets every once in a while. So usually they use the word mild to indicate that it's not a serious problem. So I'm going to keep B as a question mark, but I'm not too worried about it. Dark brown stool after iron, that's actually expected. You'd expect the stool to be darker after taking iron. Floating oily stools and weight loss. Well, I don't expect that. So remember, the pancreas secretes enzymes that help with digestion of nutrients. And so if you're not digesting your nutrients, you're going to have weight loss. And then if you're not digesting fats, you are going to have floating oily stools. So that indicates they're not digesting their fats, and it's exiting through the colon. Gluten-free meal choices for celiac disease include what? So celiac disease is a failure to produce gluten. Gluten is used to absorb rye, wheat, and barley. Okay, so gluten is used to absorb rye, wheat, and barley. So if you don't have gluten and you eat those foods, they're not going to be absorbed. They're going to go through the GI tract and cause some problems like abdominal pain, probably nausea after eating, and so forth. So it's just some general GI complaints, right? All right, so gluten-free meal choices for celiac disease, it include grilled chicken. I don't never know how to pronounce this word, quinoa. Oh, I think it's quinoa, which is so weird. Like, that's not how it's spelled. I'm going to say quinoa because I'm irritated that it sounds different than it's spelled. Steamed broccoli. Okay, that's not rye, wheat, or barley, so that's fine. Barley soup, nah, that's out. Corn tortillas with beans and salsa. That's not rye, wheat, or barley, so we can do that. Whole wheat pasta, no, that's out. Brown rice and roasted vegetables, that's fine. That's not rye, wheat, or barley. Oats labeled gluten-free. Well, if they're labeled gluten-free, then they should be fine. So remember, celiac is no rye, wheat, or barley. When teaching a client about lactose intolerance, which statement shows understanding? I can try lactase enzymes when I eat dairy. I'll avoid all dairy permanently. I should drink more milk to build tolerance. Well, that's not right. Symptoms mean I have celiac disease. No, that's not right. It means you have lactose intolerance, not celiac disease. Celiac disease is gluten. All right. So the only ones that seem reasonable are A or B. I can try lactase enzymes when I eat dairy. Which statement shows understanding? I can try lactase. Yeah, you can try that. I'll avoid all dairy permanently. I mean, no, you don't have to do that. You can try lactase enzymes. Like, try it. I would do that first. It doesn't say first, but like, we don't really tell people who have lactose intolerance they have to avoid all dairy permanently. They have to avoid any dairy that has lactose in it, and they can try lactase enzymes. So, yeah. For a client with short bowel syndrome, which indicates adaptation is improving. Adaptation is improving. So short bowel syndrome is they're born with a short small intestine. And remember, the small intestine is what absorbs all our nutrients, calories and nutrients. The large intestine absorbs water and electrolytes. So if they have a short bowel syndrome, they are very poorly nourished. It's very difficult to provide nourishment through the GI tract with short bowel syndrome. All right. So what indicates adaptation is improving? So whether you like that phrase, adaptation is improving, what I'm looking for is they're improving. So go, well, I don't know what adaptation is, but I know what improving is. So I'm going to look that they're getting better. And I know the symptoms must be poor nutrition of short bowel syndrome. Okay, so if I know short bowel syndrome is poor nutrition, how do I know they're getting better? Well, I want to look for symptoms of improved nutrition. Rising stool volume and dehydration. Rising stool, well, no, because if I have rising stool volume, that means they're not absorbing stuff that they should be. Like, you don't want rising stool volume. Decreasing dependence on parenteral nutrition. So parenteral nutrition is nutrition through the IV, which is not going through the GI tract. It's going straight to the cells through the serum, right, through the blood. So parenteral nutrition is protein, fats, and carbohydrates through an IV. So if they have decreasing dependence on parenteral nutrition, then they must be improving because they must be getting nutrition other ways. Worsening weight loss, well, no. You want to have improving weight. You actually want to have increased weight gain, new edema, and rising LFTs. Well, that's not good. So no, I don't want that. So the only one that makes any sense is decreasing dependence on parenteral nutrition. Which surgery most predisposes to iron deficiency anemia? Sigmoid colectomy, that's large intestine, appendectomy, removal of the appendix, partial gastrectomy with duodenal bypass. So remember I told you iron is absorbed in the stomach. Cholecystectomy. Cholecystectomy is gallbladder. Nothing's really absorbed there nutrition-wise. Appendectomy is the appendix. Nothing's really absorbed there nutrition-wise. Sigmoid colectomy is large intestine, and I'm looking at fluid and electrolytes. So iron is stomach. And so, yeah, I would remember iron as stomach. I just would, because especially if they ask questions about gastric bypass, for example, there are issues associated with that. One would be an iron deficiency anemia. Which statement indicates correct understanding of how to take pancrelipase for a client with cystic fibrosis? All right, so whether you know much about cystic fibrosis or not, if you see the word pancrelipase, you should say, well, cystic fibrosis must be associated with pancreas issues. And if they're taking pancrelipase, they must be taking something to help them absorb fats, right? So just go with the words. Don't say, I don't know anything about cystic fibrosis. No, you go, okay, let me see if I know what these words mean. So which statement indicates correct understanding of how to take pancrelipase for a client with cystic fibrosis? I will take pancrelipase on an empty stomach between meals. I will take pancrelipase with the first bite of every meal. I will take pancrelipase if stools become oily. I will take pancrelipase once daily at bedtime. So let's just think through this. You may know the answer to this already, but let's just say you don't. So cystic fibrosis is a chronic disease. So I don't see how I would only take a treatment if I have symptoms, right? So to me, for a chronic disease, you have to take something regularly. So I'm going to cross off C, because I would not think you would only take it if you have symptoms, because this is a chronic disease. Pancrelipase, the word tells me it's used to absorb fat. So would that help if I only take it once a day? Because I would think, like just common sense would tell me that the pancreas would secrete this lipase, would secrete it in response to fat intake. Like that just makes sense to me, just like the pancreas secretes insulin in response to carbohydrate intake. Then the pancreas has to secrete lipase in response to fat intake. So it doesn't make sense that you would only take it once a day. Now the question is it more likely you take it on an empty stomach or with the first bite of every meal? Well, how do you take insulin? Insulin is secreted by the pancreas in response to carbohydrate intake. So wouldn't it make more sense to take pancrelipase the same way that you take insulin? You take it with the first bite of every meal. We take most of the insulins you take with the meal, right? So it just makes more sense that B would be the correct answer. Now, you can memorize that. You can memorize that the enzymes you take with cystic fibrosis have to be taken with the meal. Maybe you've cared for patients with cystic fibrosis. You just know that fact. But if you have to sort of reason through this using common sense, which you use common sense. If you don't know what a question is really asking, look at the words you do understand and think through it logically. Use your common sense, your reason, logic, and say what just makes the most sense here. Findings consistent with fat-soluble vitamin deficiency, fat malabsorption include, select all that apply. All right, fat-soluble vitamins are A, D, E, and K. Vitamin A, I may say, I don't know much about that one. Vitamin D. Well, vitamin D is bones. I know that because you have to have vitamin D to absorb calcium. So I know it's bones. And also you should remember it's nerves and muscles. So bones, nerves, and muscles, musculoskeletal system sort of makes sense, doesn't it? Bones, nerves, and muscles. So that kind of makes sense. So I think of that as vitamin D. Vitamin K, you should know, is bleeding. Okay, if you have decreased vitamin K, because vitamin K is the antidote for warfarin. So if you have decreased vitamin K, you're going to bleed more. And then vitamin E, I usually think of as memory and cognition. I usually think of that. So let's see what our options are. Night blindness, easy bruising, prolonged bleeding. Well, that one, I think vitamin K immediately. Okay, so if we have low fat-soluble vitamins, I would think easy bruising, prolonged bleeding. Peripheral neuropathy, ataxia. Well, that's nerves and muscles, which I said vitamin D is nerves and muscles. Osteomalacia, fragility fractures, that's definitely vitamin D. Glossitis and angular cheilitis. Okay, that's glossitis, I think, it has something to do with the gums. And I tend, when I don't know what something is, I tend to not choose it. Petechiae that resolve with vitamin C. So I like petechiae, but petechiae, if it resolves with vitamin C, which I don't know why that would happen, but if it's vitamin C related, vitamin C is not fat soluble. It's A, D, E, and K, so it can't be a fat soluble issue. Now, if we go back up to night blindness, this is one that you can just know. Vitamin A is actually vision. Okay, so it's vision. So vitamin A is vision, vitamin K is bruising, vitamin D is muscles, nerves, and bones. Vitamin E, I usually think of as memory. So glossitis, think of the word itis, it's inflammation. So glossitis is actually inflammation in the mouth. Angular cheilitis is cracks and a lot of dryness in the lips and even the tongue. So you might get really bad cracks along the side of your mouth or even in your lips. And that's usually poor nutrition, but not fat-soluble vitamins. It may be dehydration, it could be poor nutrition. That's not the fat-soluble vitamins. All right, that's it. You may have found this more difficult. Like, I didn't know some of this stuff, Dr. Sharon. So learn some of it conceptually. I hope this helped you understand the GI system a little bit more conceptually and how to answer questions with common sense and clinical reasoning. All right, so have a great rest of your day. Take care.